Let's have a journey in head and neck anatomy and have our voice notes for this important chapter, which is very tricky for non-head and neck surgeons. Like the ENT will be superb in this chapter and some of the plastic surgeons, but for others, deep anatomy detail might be confusing, but together we can make it like a piece of cake, God willing. So let's begin it. A very famous question about a patient attending ENT clinic for removal of wax from external auditory canal. During this procedure, he starts to cough. The vagus nerve supplies the sensation of the inferior external auditory canal and is responsible for this common phenomena of coughing when the patient having their ear suctioned. Keep it in mind. Again, we stress that the last line in the scenario is very important to be read before the whole scenario, because it might be a different, separate question, had nothing to do with the whole scenario, and this will save you a lot of time. So, the contraction of which muscle can cause vocal cord abduction? This is simple, direct question, has nothing to do with the whole scenario. Dear great surgeon, it is the posterior cricoarytenoid muscle. The posterior cricoarytenoid muscle is an important muscle as it is the only muscle that abducts the vocal cord. It extends from the back of the cricoid to the muscular process of the arytenoid and is supplied by the recurrent laryngeal nerve. It's very important to explain to the patient the complications of the surgery that might occur. And in this question, we are talking about a surgeon explaining to the patient that he has a probability of having some dropping of the left shoulder and weakness of the shoulder elevation as a sequence of this surgery. So, what nerve will be sacrificed? Here we are talking about the spinal root of accessory nerve, the nerve number 11, which crosses the posterior triangle of the neck and is sacrificed in the radical neck dissection. Section of the spinal root of accessory nerve result in unilateral paralysis of the trapezius, because we all know that this function is done by the trapezius, elevation of the shoulder. So if he has some dropping of the left shoulder and weakness of the shoulder elevation, this is due to affection of the trapezius, and the nerve will be severed, will be the accessory spinal nerve, and is manifested as shoulder dropping and difficult in elevation of the arm above 90 degrees. Again, embryology. Where to study embryology from? Nothing to worry about. You have to take it like piecemeal. When you face a question from embryology, take it, because it's overlapping with many chapters. So when you are studying head and neck surgery, for example, or head and neck anatomy, the applied anatomy will be the embryological origin of the head and neck structures. So a very famous record question about the stapes. What is the origin of the stapes? The stapes is derived from which embryological structure? It's from the second pharyngeal arch. The pharyngeal arch are derivatives of the embryological branchial system. Derivatives of the second branchial pharyngeal arch include stylohyoid ligament and upper body and lesser horn hyoid, muscles of facial expression, and posterior belly of digastric, and the styloid and the stapes. And take care, the arch is not the same as the pouch. The second pharyngeal arch is not the second pharyngeal pouch. The derivatives of the stapes derived from the second pharyngeal arch. The styloid ligaments, upper body of the lesser horn of hyoid, muscle of facial expression, and posterior belly of the digastric, as well as the stylohyoid and the stapes, are from the second pharyngeal arch. The foramina of the skull are frequently asked in the exam, and no, for non-head and neck surgeons, it might be an irritating question. But with time and with these voice notes and with frequent revision, you will get it all. Take them piecemeal. This is your trick. If you can read it once, but never expect to have them memorized once, especially if you are not a head and neck surgeon, and this is very common. No worries. So, let's talk about the foramen magnum structure passing through them. The foramen magnum transmit the vertebral arteries the anterior and posterior spinal arteries, and the lower part of the medulla and its surrounding meninges, and the spinal root of the accessory nerve, of course. And the hypoglossal nerve exists through the hypoglossal canal. Take care. The hypoglossal nerve exits through the hypoglossal canal, and the internal carotid artery passes through the carotid canal. The carotid from the carotid, the hypoglossal from the hypoglossal. But take care. The internal carotid artery passes through the carotid canal, then into the foramen lacerum. But the glossopharyngeal and the vagus exit via the jugular foramen. Those are very important structures passing through foramina. Take them piecemeal and you will master them. Again, the foramen magnum transmits the vertebral artery, anterior and posterior spinal arteries, and the lower part of the medulla with its surrounding meninges, and the spinal root of the accessory nerve, of course. The spinal root of accessory nerve, which is supplying the trapezius. Yes, you are doing great. The anterior cranial fossa of the skull is formed by the orbital plate of the frontal bone, the lesser wing of the sphenoid, and the cribriform plate of the ethmoid. Those are very important combination to form the anterior cranial fossa. The pterion is very important weak point in the skull. And by the way, it's frequently asked in the exam. It's a junction where the frontal, parietal, and the greater wing of the sphenoid and the temporal bone are in close proximity in the pterion. The clinical consequence of the skull fracture at this area can be very serious because this bony area is particularly thin and overlies the anterior division of the middle meningeal artery, which can be torn by the skull fracture and result in extradural hematoma. Very important question in the exam, by the way, either in the structure or the clinical applied anatomy regarding the pterion or its name. You will be asked about the middle meningeal artery passing through there, or the branch the middle meningeal artery is branching from, or the pterion and its forming bones, and the trick will be in the greater wing of the sphenoid, not the lesser wing of the sphenoid. And of course, the probability of happening of extradural hematoma from middle meningeal artery rupture. The middle meningeal artery is a branch of the first part of the maxillary artery. It reaches the middle cranial fossa through the foramen spinosum to lie between the meningeal and endosteal layer of the dura. Again, between the meningeal and endosteal layer of the dura. It passes forward and lateral grooving the squamous part of the temporal bone. Then it divides into large anterior branch and small posterior branch, the frontal and parietal, and it divides into anterior and posterior branch opposite point 20 mm above the center of the zygomatic arch, and is the main cause for extradural hemorrhage, and the main site to be injured at the pterion. Dear great surgeons, the triangles of the neck is very important, and specifically the posterior triangle of the neck. Let's get familiar with the contents of the posterior triangle of the neck. The contents are nerves, artery, veins, and lymph nodes, as well as the brachial plexus, which lie deep to prevertebral fascia. So, regarding the nerve, there will be the spinal accessory nerve, of course, which is supplying the trapezius and the sternocleidomastoid, and cervical plexus, which is the lesser occipital, greater auricular, transverse cervical, and supraclavicular. The arteries will be the third part of the subclavian artery, the transverse cervical and suprascapular arteries. Both are branches from the thyrocervical trunk, by the way, and the occipital artery. The veins will be external jugular vein and the lymph node, as well as the inferior pili of the omohyoid. So the inferior pili of the omohyoid is within the posterior triangle, while in the anterior triangle you find the anterior pili of the omohyoid. Take care. The inferior pili of the omohyoid muscle originate at the superior border of the scapula, and the superior pili of the omohyoid is the central tendon, which is bound to the clavicle, by the way, and it inserts in the inferior pili the central tendon, while the superior pili is inserted in the hyoid. You can roughly say that the origin of the omohyoid from the scapula to the hyoid. So take care. If you take it as separate muscle from the inferior pili and superior pili, so the inferior pili will be originating at the scapula and inserting in the central tendon And the superior belly will be starting from the central tendon to the hyoid bone. And take care, it's supplied by the cervical plexus from C1 to C3. And this reminds me of the digastric muscle, which has two bellies as well. The two bellies unite by a tendon, just like the omohyoid muscle. It originates, if we are talking about the anterior belly of the digastric muscle, as the digastric fossa, present lateral to the symphysis mentae on the lower border of the mandible, while the posterior belly as a mastoid notch on the temporal bone, and they are inserted into the intermediate tendon at the hyoid bone. The arterial supply of the digastric is the anterior belly supplied by the mental branch of the facial nerve, while the posterior belly by the occipital artery. So these are tricky questions in the exam, but the most tricky will be the nerve supply, because the anterior belly of the digastric muscle is supplied by the mandibular division of the trigeminal nerve via the myelohyoid nerve, while the posterior belly with the facial nerve. So posteriorly with the facial nerve for the digastric, but anteriorly via trigeminal nerve, mandibular branch. And another trick regarding the digastric muscle is that the anterior belly is branching from the first branchial arch, while the posterior belly from the second branchial arch. Take care. The anterior from the first, the posterior from the second branchial arch is the digastric muscle. So they have different nerve supply and different embryological origin. But it's one muscle, digastric muscle. The vertebral level is continuing even in the head and neck. So the hyoid bone is at C3. The thyroid cartilage is at the level from C4 and C5, while the cricoid cartilage is at level of C6. It's very important in the exam, by the way, those anatomical vertebral level. Hyoid C3, cricoid C6. Very famous question in the exam regarding the nerve injury during thyroidectomy. So, a damage to external laryngeal nerve can affect which muscle? The external cricothyroid muscle is supplied by the external laryngeal nerve, and all other intrinsic muscles of the larynx are supplied by the recurrent laryngeal nerve. So you must not be confused and never forget it. The external cricothyroid muscle is the only muscle supplied by the external laryngeal nerve, and all other intrinsic muscles are supplied by the recurrent laryngeal nerve. External cricothyroid with external laryngeal nerve. Take care. A very famous question in the exam regarding the infrahyoid muscles, or the famous strap muscle. They are a group of 4 pairs of muscle in the anterior part of the neck, in the anterior triangle. The 4 infrahyoid muscles are sternohyoid, sternothyroid, and thyrohyoid, as well as omohyoid. Again, sternohyoid, sternothyroid, thyrohyoid, omohyoid muscles. And of course, they are supplied by the ansa cervicalis C1, 2, and 3. And during thyroidectomy, you have to split them away. And if you have to cut them, you cut them as high as possible to prevent cutting or injuring their nerve supply, which is the ansa cervicalis. And they are called strap muscles because they are long, flat, similar to a belt or a strap, by the way. The cavernous sinus is very important in real life and in the exam because it's a dangerous area due to its important content passing through them. The cavernous sinus contains the internal carotid artery, the oculomotor nerve, the trochlear nerve, the abducens nerve, and the upper 2 divisions of the trigeminal nerve, the ophthalmic and maxillary. The mandibular, by the way, passes lateral to the cavernous sinus through the foramen ovale, so take care. So, on the lateral wall of the cavernous sinus from above downward, the oculomotor, trochlear, ophthalmic, and maxillary nerve, while the internal carotid artery passes through the lower medial part of the cavernous sinus with the abducens nerve on its lateral border. So take care. The trick is the oculomotor and the ophthalmic and maxillary branches of the trigeminal are content of the cavernous sinus, but the optic nerve is not within the cavernous sinus. Has nothing to do with the cavernous sinus. We have the internal carotid within the cavernous sinus, but the external carotid is not within the cavernous sinus. We have many nerves inside the cavernous sinus, not including the facial nor the optic. Take care. The arterial tree again is very important in the exam, and you have to have a photographic memory of an illustrative photo and keep it in mind to recall it when you need it. It will be more easy than memorizing the Harry Potter spells. Inferior thyroid artery is a branch from thyrocervical trunk, which is a branch from subclavian artery, and it crosses the vertebral artery to supply the thyroid gland. This is the inferior thyroid artery. And remember that the superior thyroid artery is a branch from external carotid artery, and it's the first branch of the external carotid artery in the neck, by the way. Take care, during routine head and neck examination, you can identify arterial pulsation on the mandible at the anterior border of the masseter muscle. Which artery is this? This is the facial artery, curling around the mandible to the face. It continues as a tortuous course to reach the medial canthus of the eye. So this is the facial artery pulsation you are feeling in the mandible at the anterior border of the masseter muscle. The facial artery is the fourth branch of the external carotid artery and the branch of in the carotid triangle, and it's very tortuous, by the way, and this serves as a function purpose. That means that the artery can accommodate head and neck movement as well as pharyngeal expansion as during swallowing and facial movement. It arises above the ascending pharyngeal artery and passes diagonally up from the underneath the xyloid and digastric muscle. The vessel arch over the submandibular gland in a groove on the posterior surface. From there, it arches superiorly over the mandibular body in close association with the lower part of the masseter. The vessel then travels anteriorly and superiorly across the buccal region to reach the angle of the mouth, and then passes upward along the side of the external nose and terminates as an angular artery. Again terminates as an angular artery near the medial commissure of the eye. The angular artery is essentially a terminal branch of the facial artery. The facial artery is the fourth branch of the external carotid artery. Again, take care, and terminates as the angular artery. And it's tortuous. And now you understand why it's tortuous, and it's important to be tortuous. Trauma is very important, and examination in trauma is very important, and anatomy and orthopedics as well as trauma are overlapping together. And this is a very clear example for this question. A question asking you that you are examining a patient after RTA, and during the examination you identify the first cervical spinous process. Which cervical vertebra you have identified? This is not a trauma. This is not an ortho. It's an anatomy. So take care. And it's very important. We are talking about C7. C7 is also known the vertebra prominent. It has the first spinous process. As C1 to 6 are covered with ligamentum nuchae. And you can feel it yourself on yourself. Put your hand on your back, and the first vertebra prominence you will feel, this is the C7. The cervical spinous process first is palpated by you will be C7, the vertebral prominence. Why C1 to C6 are not palpated first? Because they are covered with ligamentum nuchae. Dear great surgeons, take care. The anatomy of the jugular vein is important, given that it is the site of insertion of the cerebellar venous catheters. The internal jugular vein originates at the jugular foramen. It begins posterior to the internal carotid artery and then passes to the lateral side. As it descends in the carotid sheath, it lies lateral first to the internal, then the common carotid artery within the carotid sheath. Again, as it descends in the carotid sheath, it lies lateral first to the internal, then the common carotid artery within the carotid sheath. It then passes anterior to the subclavian artery to join the subclavian vein to form the brachiocephalic vein. The internal jugular vein receives a lymphatic trunk at its union with the subclavian vein. Take care, the internal jugular vein receives lymphatic trunk at its union with the subclavian vein. The internal jugular vein is usually considerable size, and the right internal jugular vein is usually larger than the left. The external jugular vein drains into the subclavian vein. Take care. Dear great surgeons, take care. The subclavian vein is a continuation of the axillary vein, beginning at the lateral border of the first rib. Always remember that the artery is from proximal to distal and the vein from distal to proximal, because the vein is drainage. So the subclavian vein is a continuation of the axillary vein, beginning at the lateral border of the first rib. It passes anterior to the scalene anterior, and the subclavian and the internal jugular vein unite to form the brachiocephalic vein. Subsequently, the left and right brachiocephalic vein unite to form the superior vena cava. The wholly superior vena cava is a formation of the left and right brachiocephalic veins. The thoracic duct enters the left subclavian vein, and the brachiocephalic trunk is a branch of the aortic arch, which divide to form the right subclavian and right common carotid artery. Don't confuse the brachiocephalic trunk and the brachiocephalic vein. The brachiocephalic trunk is a branch of the aortic arch which divide to form the right subclavian and right common carotid arteries. But the left and right brachiocephalic vein unite to form superior vena cava. And by the way, remember always that the thoracic duct enters the left subclavian vein. Take care. The parathyroid gland are very important in real life and in the exam because they are ovoid bodies. They are golden yellow and can be easily mistaken as a fat globule if you are not familiar with the specific color of the golden yellow of the parathyroid gland intraoperative. And that's why we can use methylene blue to identify the parathyroid intraoperative, or we can put the extracted parathyroid gland on a glass of water. If they are floating, they are fat. If they are drowning, those are the parathyroid glands, because they are not a fat globule. They just are ovoid bodies. The parathyroid glands lie external to the fibrathyroid capsule. Again, lie external to the fibrathyroid capsule, but are embedded in the posterior surface of the thyroid gland. It's believed that the parathyroid hormone is secreted early in the fetal life by the Schiff cells to regulate calcium metabolism of the fetus. And the inferior parathyroid gland developed from the endodermal cell of the third pharyngeal pouch. Again, the inferior from the third and the superior from the fourth. So, again, the inferior from the third and the superior from the fourth. Take care. The embryological origin is very important regarding the parathyroid gland. And they receive blood supply from the superior and inferior thyroid arteries. Take care.